Hello, I'm Joe Parks, and I'm the medical director for the National Council, but I'm also a psychiatrist that practices, and for the last 10 years has practiced in a primary care setting. Before that, I practiced at community mental health centers and university clinics, and so I've been on both sides of that aisle, and I wanted to talk to you today about the differences in treatment planning and what both sides mean when they use the word treatment plan, because it's real different what a treatment plan is in primary care from what a treatment plan is in a community mental health center or a behavioral health clinic. It's like talking about apples and oranges. One thing is you'll find that the behavioral health treatment plan is a lot longer. They often run 8-10 pages. Part of this is because it is also seen as a therapeutic and psychoeducational intervention with the patient. It's done to educate, but also as a way, as really a form of psychotherapy almost, to come to a common understanding, which advances, of course, the patient's, or in our case, we often call them consumers, understanding of what's going to go on in their care. It's also a tool for getting engagement. So it's not just a medical document. It is also a procedure and an event. And for that reason, it's much more attentive to how the patient or the consumer, the person, may think about their care and what their goals may be on the outside of the treatment setting than a general healthcare treatment plan would be. So be prepared to see a much longer document, a document that has a lot more discussion in it regarding social issues, regarding personal goals, and how it may relate to the care. Now, the medical issues you're treating, the medical conditions you're addressing, are increasingly being made a part of these behavioral health treatment plans. People with serious mental illness have more chronic medical illnesses and they die early. And behavioral health providers are very aware of that and want to do something. So they're doing their best to move this medical viewpoint into this behavioral health treatment plan that now you're going to be a part of. You know, another thing you'll find real different about the behavioral health shared care plans or treatment plans is they are framed almost completely in non-medical goals. It's about somebody wanting to play with their grandchildren, somebody wanting to be able to go out and bowl, or somebody wanting to get a girlfriend. So it's in very personal goals. And so the way you need to approach this that I'd recommend is to find a way to have something in that treatment plan, say it's bowling, consistent with what you're recommending medically. So instead of saying, you need to control your diabetes, look at this hemoglobin A1C, it's not good. You need to talk about, I know your goal is bowling, but of course, if you are feeling weak, if you have low energy, if your feet hurt too much from that diabetic neuralgia, if we don't control the diabetic neuralgia, you won't be able to bowl as much. One thing I've found both medically, clinically, and frankly in my life, and politically certainly, is you can never sell someone else based on your values. You can only sell a change or an action to someone based on their goals and values. So whenever you want somebody to do something else, the reason behind it has to be a reason that's important to them. Which I don't know about your patients, but with mine, it's often very different than my goals for them. But I need to look and search for something in their goals that would motivate them to go forward with the medical recommendation I'm making, which often means linking a clinical action to some ability that they seek to have to get some social good or activity in the outside world. Give it a try. It's a kind of interesting way to reframe thinking. I think you'll find it's surprisingly effective with a good portion of your patients. Not all of them, of course, but a good portion would be nice.